As we are getting started, hit the record button. Again, welcome and thank you for joining the session, Addressing Internalized Stigma and Illness Identity, Empowering Recovery and Self-Advocacy for Individuals with Mental Health Conditions. Today's webinar is hosted by DBHR through the Washington State Healthcare Authority. Today's session, we are in a webinar format, so please utilize your chat features, the Q&A feature to engage with today's presentation. You can send a message to everybody or just specifically to me as the panelist in that chat. Thinking about today's session, it is being recorded. So just be mindful of that. And additionally, the slides for today's session and all of the materials from today's session, handouts, will be sent via email after we conclude today's session. Just a brief note about the use of AI. I know some folks may have attended previous training sessions where there may have been automated note-taking bots. And we just want to be mindful that prior approval needs to be provided in the event that you need an accommodation or access to AI for an accommodation. Please reach out in advance and we will get you situated to make sure that the session is accessible for you. Okay, I see that someone is noting that the chat is not accessible. Let me make sure. Let's see if I can enable that feature. It looks like the chat feature might not be accessible right now. We do have Q&A. I don't see an option to enable the chat. So my apologies. Please feel free to direct everything right into the Q&A. I will have access to that. Thank you so very much. And thinking a little bit deeper about today's session and my approach to facilitating a learning community, we just want to be mindful that everyone here has an opportunity to co-learn, to leverage your knowledge and deep expertise in the work that you do to share and participate in today's meeting, and really to have an opportunity to learn some new information, to lead with curiosity, while we are simultaneously just maintaining respect for all of the diverse and complex, beautiful identities that we hold in this virtual space. And with that, I'm eager to get to know a little bit about everyone here today. So if you can, put in the chat or in our Q&A to your level of comfort, your name, your organization, your role, if you'd like, your interest in today's topic. Again, you could put that right in that Q&A. Your name, your organization, your role. Where you're coming in from. Welcome, folks. Oh, I see some case managers, residential service coordinators. Great to have you here. Employment consultant. Nice to have you. Case manager. Oh, for the mental health court. That is amazing work, hard work. Supportive housing, peer counselor, welcome. Adult and family services, great to have you. I see some really diverse individuals coming in from all different types of service modalities. That is fabulous. Contract manager, community action, FCS, case manager, great to have you. Welcome, welcome. Northwest Center Manager, great to have you, Rebecca. Program Coordinator, Program Manager, awesome. So again, a lot of diversity in this room in terms of where we're coming from, the services that we provide, but all with that aim of helping people to achieve their potential, to be able to access their aspirations, wellness aspirations, and recovery. Great adult and family services, employment specialists, compassion center. Nice, Michelle. Excellent. So thinking about today and today's topic, this is a series that Washington State was really interested in supporting on cultural responsiveness. So far, we have reviewed in our 6-session series, cultural humility, supporting individuals within the LGBTQIA plus community, implicit bias, and now we're on addressing internalized stigma and illness identity. In March, we'll be moving on to supporting individuals with mental health conditions and autism spectrum disorder, or more of that like neurodivergent umbrella. And in April, we'll be looking at supporting individuals in Washington State and tribal communities. So hopefully you have attended some past sessions. Maybe I'll see you in some future sessions, but this is all about, again, that cultural responsiveness, right? Our ability to integrate intersecting cultural identities into the work that we do, providing services that honor, acknowledge, and are responsive to the different cultural backgrounds, cultural facets that each person that we're working with holds. So for today, we are digging into this piece about stigma, kind of piggybacking off of the implicit bias session that we had last month. We're looking at stigma, illness identity, and this piece about the theoretical models of disability, which is really interwoven into this piece of stigma and illness identity. We're going to look at the historical models in the context of stigma, especially in our community as mental health practitioners and providers. And then we're going to get deep down into some strategies to counteract internalized stigma, to promote strength-based identity or a positive disability identity in our practice. Thinking about the series, just an overall review, when we think about cultural responsiveness, it really involves understanding and effectively including and responding to the combination of intersecting cultural variables, right? That full range of dimensions of diversity that an individual can bring into service, into our interactions. So really, when we think about cultural diversity and cultural responsiveness, they go hand in hand. And we want to be mindful as we're building our responsiveness, how we're considering all cultural facets, right? Cultural identity is complex and multifaceted, and it's the driving force behind who we are. That piece of intersectionality, right? That term that was coined by Kimberly Crenshaw, right? Refers to that interconnected nature of these social categorizations as you see here, race and gender, disability or ability, and that these systems are interdependent and can be impacted by points of advantage or points of disadvantage. And so today we're going to be focusing on that piece of disability, right? Which we see often in the work that we do, providing mental health services throughout the state. You may be working with people who have varying disabilities. Maybe if they are experiencing a psychiatric disability, maybe they have an additional medical condition, a chronic health condition that is a comorbid disability. So when we think about disability in the United States, it is actually one of the largest minority groups, according to the Center for Disease Control, the CDC, in 2023. Over 60 million Americans are living with a disability as of 2023. And according to the NIH, we see that approximately 23.1% of American adults or individuals in the US experience a diagnosable mental health condition. So that's like 1 in 4, 20% have a psychiatric disability. And so, again, this is something that is pretty prevalent. When we think about individuals with disabilities, it's not only the largest minority group in the US, It's the group that anyone can join at any point in time. Anyone can join through an acquired disability, this minority group in the US. We think about disability. The Americans with Disability Act defines disability as a person who has a physical or mental health condition that substantially limits one or more major life activities, right? So when we think about disability, it's not just a medical term, it's a legal term used to support accessing rights and services, benefits, entitlements, right? And when we think about major activities that can be limited by the presence of a disability, it can be things like things specific to our life domains, the four life domains of living, learning, working, and social. So we want to be, mindful as we're kind of narrowing down today's topic, that this topic can apply to disability across the board for individuals with varying health conditions, chronic health conditions, but we're really going to be focusing a lot on psychiatric disability. And when we think about disability and our topic of illness, identity, and stigma, a big portion of what can come up for folks can include this concept of ableism. Ableism is a set of beliefs or practices that really devalues or discriminates against a person with a disability. And there's often this assumption that people with a disability need to be fixed in one way or another, right? It's comparing individuals to what is believed to be the ideal or the norm, the normative group, right? The normative group, meaning people without disabilities. Ableism is intertwined in our culture due to many limiting beliefs about what disability is or what it isn't, and how people learn through various methods of how you view, right? What are the beliefs about people with disabilities and how you treat people with disabilities. And there's also this piece about able privilege, right? And able privilege, also referred to as ability privilege, is very pervasive in our society. And it's this preferential treatment for individuals that may not experience a health condition, a disabling or qualifying health condition. And so when we think about ableism, it is very much intertwined with stigma, right? When we are exposed to stigmatizing views, attitudes, belief systems, that can generate that piece of ableism, right? There's almost this like symbiotic nature between these two factors. Stigma begets ableism, and ableism grows stigma. And so when we think about stigma, what comes to mind for folks? Let's take a moment to kind of refine our collective understanding and working definition of stigma. That way we're kind of using our verbiage in very concise and accurate manner. So go ahead and take a moment. You can put into that Q&A. What comes up for you when you hear the word stigma? What comes up for you when you hear the word stigma? What's your working definition? How do you define it? Shame, Nicole. Yeah, unavoidable and unchangeable. So fixed set of belief, Elizabeth. Negative reactions, preconceptions, false understanding, negative impact, Victor. Yes, stigma is often having very deleterious effects on people that are significant. Thank you. Discrimination based off of bias. Yes, yes. When that stigma is put into action, there is discrimination. Yeah. My thoughts when I hear stigma is negative label belief of a person or a group. Yes. Fear. Yeah. Hopelessness. Something that can define someone to others. Yes. So having like this preconceived notion, Tim, of what it means to be a part of this group. Ignorance that was accepted as truth by the majority. Thank you, Dusty. Yeah. Ignorance. The uninformed. The um, falsehoods about a group that is just fact, right? Feeling left out, treated like an outsider. Christina, yes, we're going to talk about that. That piece of otherness, being othered, assumptions, being uninformed. Yeah, yeah. So I hear this resounding piece of, just not being knowledgeable, having, inaccurate information, fear, right? All of these negative connotations. Absolutely. So you guys are spot on. Stigma refers to a set of negative beliefs and attitudes that society or individuals hold about particular characteristics, attributes, or certain groups or conditions. When we think about mental health, right? The context of mental health, stigma involves negative stereotypes and misconceptions about mental health conditions that can very much result, as you guys noted, in being marginalized, devalued, or that piece of discrimination being treated unfairly. Right? According to SAMHSA, when we think of stigma, it's when someone, even yourself, views a person in a negative way because of that presence of a mental health condition. And there are different types of stigma. Public stigma is when there's a general public consensus, right? Public has very negative attitudes about a group. And in our session, again, we're going to focus on those with mental health conditions. So, very negative general public consensus about people with mental health conditions. There's self stigma, that internalized view of self, right? Taking societal um, connotations, negative belief sets or attitudes, and applying it to self. And then there's structural stigma, right? Where there's institutional policies and practices that can restrict opportunities and rights of individuals with mental health conditions. When we think about stigma, it's important to know that there can be label avoidance stigma. And that refers to when an individual avoids seeking help, right? Someone with a mental health condition is going to avoid seeking help, disclosing their mental health condition in an effort to avoid being labeled or stigmatized. And there are some pretty standard components of stigma. One are stereotypes. I think you guys identified that pretty consistently, right? People with mental health conditions may not be reliable, can't handle stress, right? That's an example of a stereotype, an oversimplified, fixed idea about a group of people, right? And so that might, right, in giving that some context, an employer might believe that hiring someone with a mental health condition will lead to poor job performance or absences, right? That's a stereotype. Prejudice involves preconceived opinions or judgments, feelings, often very negative, directed towards individuals based on that group membership. And this can manifest as irrational attitudes and emotions towards that group, or in our context, people with mental health conditions. And so that might be, I feel uncomfortable around people with mental health conditions because they're not predictable, right? They're unpredictable. And then there's discrimination. And discrimination is that behavior piece, right? Resulting from prejudicial attitudes and stereotypes. And it's when someone is being treated unfairly or unjustly, right? We don't hire people with mental health conditions, right? That's going to then move into that realm of just not an attitude now, it's a behavior, and it's a behavior that is a result of that prejudicial thought or belief. And so we can see examples of this so frequently. It's prevalent. Um, let's take, for example, right, let's see if we can spot the stigma. Here you see a newspaper cartoon or a little image where there is a gentleman sitting at a very official desk in what appears to be an office. And there is a woman explaining to the officiant or this legislator, sir, these gentlemen from the U.S. Equal Employment Opportunity Commission are here to explain new rules on mental illness in the workplace. And as you can see, around the desk, the people coming in, supposedly from the EEOC, are individuals that are wearing no clothing and seated in a chair, right? They have this very inappropriate facial expression, this like this grin, right? Um, they you see someone wearing a Napoleon outfit. What are some of the implied things that are emphasizing prevalence of stigma, of public stigma? What are we seeing here? Right, let's spot the stigma. What is this artist conveying to the public in this cartoon? You can put it in the chat. What are some of the messages, the implied messages here? People with disabilities don't know how to behave. People with disabilities look a certain way, right? Yes, the straitjacket implies that the person is, unpredictable, not safe, needs to be controlled, or to have their movement restricted. Emotional outbursts, behavioral outbursts, right? We see this person in the forefront that has their tongue out and, they are kind of like staring at you, the reader. Then we see someone in this, what appears to be this plaid shirt. And it looks like they're holding an axe. And on that axe is seemingly a dark substance on the tip, right? So this was something in print that was sent out and consumed in relationship to the discussion of the Equal Employment Opportunity Commission and how they were advocating for inclusion and accessibility in the workplace for individuals with mental health conditions. When do you think this was made? When do you think that this was created? What year would you take a guess? 2000s? Perception that people with mental health issues are all extreme, delusional, inept, incapable. Yes, that's the message that is being conveyed here, right? That people are not stable. 2000, 2024, 2000s, 1990s, 1970s, 90s, 86, 2010, we're all over. Yeah, so this was printed in December of 2016. December of 2016. And I fear that things to come in relationship to similar topics, given where we are in terms of political climate, will denote similar messages and or worse, right? December 2026, this was in print. And we can see pervasive stereotypes, prejudicial images, conveying that people are inept, unpredictable, violent, right? Very negative connotations. There is this pervasive nature of mental health stigma in society, and it is significantly exacerbated by a multitude of factors, one being this piece about media. These platforms not only reflect, but also perpetuate harmful stereotypes and prejudicial beliefs that contribute to the marginalization of individuals with mental health conditions. And so it's really important that we identify these sources of disability stigma. Where are they coming from? And how are we speaking out in advocacy to counteract them? So thinking about factors contributing to disability stigma, we've identified media is one of those variables. What else comes up for people? What are the ways that you have observed that these notions, stereotypes, beliefs, prejudicial beliefs, discriminatory behaviors, how do they persist? How are these things just still remaining prevalent? What are the modes that they are conveyed? What do you say? Put in the chat. What factors do you observe perpetuate disability stigma? Um, Poor modeling by leaders. Yes, Christy. And I think about this question that you asked every night when we think about the elimination of DEI and the current state of employment protection for folks with disabilities. Every night I think about this and the work that we do, that I, you know, committed my career to, what is to come. And I don't have any answers. Right now, as it stands, the ADA, that piece of vital legislation that protects the rights of individuals from discriminatory practices in hiring, in the workplace, in education, that remains. I am a part of many advocacy groups that are watching diligently any advances to roll back or reduce or negate those legal protections. But I hope every night when I go to bed that I will wake up and these things will still be in place for some of the most vulnerable individuals that we serve in our public mental health service system. Yeah, thank you. Great question, Christy. Um, so poor modeling by leaders is another variable that contributes to disability stigma. Anything else that comes up for folks? Um, Dusty, yes, practitioners, those doctors that you might see. Nicole, bias discrimination, under education of people, right? Not having access to information, absolutely. Right? There are many contributing factors that have historically contributed to disability stigma. Social media, traditional media, pop culture being, movies, television shows, right? These platforms reflect and perpetuate stereotypes. We also see um, things that include that piece of lack of education and awareness. You mentioned the structural factors like the healthcare system itself, like medical doctors. Maybe sometimes we have challenges with the prescribers or the prescribing providers that may really adhere to um, a more medical model of disability, right? And so what I mean by that is that there have been different theories of models of disability that have informed treatment and service. And that model, or the theoretical model of disability, has impacted how we conceptualize treatment, how prescribings conceptualize treatment, how practitioners think about clinical services. That can be a huge factor in this equation. We also see, things like legislation and policy, right? Legislation and policy can contribute to how people perceive individuals with mental health conditions and disabilities. For example, in New Jersey, where I'm from, there's involuntary outpatient commitment, and having that law on the books where people are not meeting criteria for inpatient hospitalization, right? They can be court mandated to outpatient community services. And that may have perpetuated beliefs that people with mental health conditions, even when they're not meeting criteria for inpatient commitment, right, they need to be forced, legally mandated into treatment because they can't make decisions for themselves. So inadvertently, how legislation is developed and passed could absolutely impact disability stigma. Dusty, controlled banned books, yeah, thinking about that piece of like culture, right? It could certainly come down to pieces of literature, art, right? The messages that are conveyed in our culture itself. Absolutely. But I really want to narrow down this piece about theoretical models, because that is a huge contributing factor that is often overlooked by practitioners. There has been, throughout history, different perspectives on the etiology of mental health conditions, the focus of treatment, and how we go about viewing the prognosis of mental health conditions. And so when we think about these theoretical models of disability, there's been many iterations. First, we see the moral model of disability. And this is one of the oldest perspectives on disability. And it could be deeply rooted in historical and cultural beliefs. This model views disability through the lens of morality, often associating disability, mental health conditions with sin, moral failing, divine punishment, right? It interprets disability as a reflection of an individual or maybe even their family, someone's ethical status, their spiritual status. And so historically, this moral model of disability has been prevalent in many societies, and it influences how individuals with disabilities were perceived and treated. In many settings, cultural or religious contexts, disability has been seen as divine retribution for sins or misdeeds by the individual or even their ancestors. And then we see in the early 1900s, the eruption, the development of this medical model of disability, which is going to be your third column from the left. The medical model of disability views disability as a problem of the individual that requires very hierarchical medical treatment. Hierarchical meaning that the doctor is the person with the knowledge, skills, abilities to cure you or to treat you, and they should not be questioned, right? There is this hierarchy of treatment. And this particular model of disability has been very impactful in terms of public stigma surrounding mental health conditions. Again, this model was very prominent in the early 19th and 20th century, and it frames mental health condition within this context of over-pathologizing and a defect within the individual that must be diagnosed, treated, maybe cured, most likely not, right? There was not a lot of discussion about curing or recovery. While this particular perspective has contributed to some advances in medical science and treatment, it also inadvertently perpetuated a view of mental health conditions as abnormalities, things that need to be corrected, heavy focus again on pathologizing of problems, of deficit, really fostering societal stigma. So historically, this medical model reinforced negative stereotypes and misconceptions, right? This model doesn't really recognize individual strengths and capabilities. It relies heavily on over-pathologizing, leading to marginalization and devaluation of the person with the mental health condition, portraying them as fundamentally flawed or inferior, right? And, consequently, this model has ingrained a societal mindset that mental health conditions are a personal failure or weakness, and just further entrenching that public stigma. When we think about the medical model's emphasis on diagnosis and treatment, it really, again, contributing to that power imbalance between healthcare providers and the individual, right? That dynamic really could, what we see in that historical context lead to dependency on medical authority, where individuals are seen as passive recipients of care rather than active agents in their own recovery. And so this framework can really diminish this sense of autonomy or self-efficacy. It can perpetuate, again, like the societal prejudices, stigma. Um, and when we think about the implications of the medical model, we see a lot of that structural stigma, right? Discriminatory practices embedded in laws, policies, institutional behaviors that have been justified by the medical model. Policies that limit the rights and opportunities of individuals with mental health conditions. And again, heavy emphasis on this piece of symptoms, diagnosis, labels, conveying defectiveness, incompetency, inability, disparity, or even infantilization, right? Looking at the person like they are not a capable adult. And within this model, and to some extent the moral model, this was really a birthplace of mental health conditions as being pejorative, slurs, way to almost strip people of their humanity. And this was especially during a time when primary treatment, right, thinking about like the 19th century, primary treatment for individuals with mental health conditions was very inhumane, right? It's very hard to carry out treatment if you are looking at someone in a way that they still have their humanity intact, right? And so there was almost an intentionality to this method, where, what do I mean by inhumane treatment? Well, when we think about this time frame historically, there was the use of asylums or poorhouses, physical restraints, um, isolation, bloodletting, or purging. There was ECT, lobotomies, hydrotherapy, forced sterilization, induced insulin comas, right? We saw a lot of during that late 19th century, early 20th century, just treatment that was really dehumanizing. There was also that eugenics movement promoting the view that disability was undesirable and needed to be purged, right, from society. And many of those proponents of these treatments or even eugenics were scientists and doctors and policymakers. And so when you think about these models, they really are embedded in the development and prevalence and persistence of societal stigma, right? It was a means of conveying and sustaining otherness. Otherness is a term that was coined by Simone de Beauvoir, and it was this prominent existentialist philosopher developed a seminal work on women in the 1940s, late 1940s, and her book was titled The Second Sex. But the concept of otherness really transcends any one cultural group, right? The concepts are applicable to all marginalized, uh, historically minoritized groups, right? So otherness refers to the process by which a dominant group defines and marginalizes a subordinate group by defining them as fundamentally different and inferior. And this dynamic is really central to understanding social hierarchy and power relations when it comes to marginalized groups. So otherness and disability, very, very relevant in how society perceives and treats individuals with disability. And so there's this piece on social exclusion, right? That society defines individuals with disabilities as the others, viewing them as different and outside the norm, and can at times endorse a process of othering, reinforcing social exclusion or segregation. There's this piece on negative stereotyping that will perpetuate stigma and discrimination that goes hand in hand with otherness, right? Involving attribution of negative characteristics to that marginalized group. right? People with disabilities, as we see, are often subject, as we noted in that news clipping, right, of these stereotypes, depicting them as incapable, violent, unpredictable, right? And then we see, in terms of looking at that concept of other, some key pieces relating to perspectives of otherness within the disability community, right? And so that can be objectification, right? People with disabilities are often not seen as whole individuals, or rather objects of inspiration or charity or pity. We also see this piece of different and separate. People with disabilities can be viewed as fundamentally different from individuals without disabilities, and again, can be segregated into other educational settings, professional settings, social settings, etc. We see this piece of simplification. The diverse experiences and capabilities of people with disabilities are simplified into stereotypes, or this concept of unchanging with otherness, right? People with disabilities are perceived as unchanging with their identities and potentially seen as fixed and limited by their disability. Or passivity, people with disabilities are seen as passive and dependent, infantilized. Invisibility, the experience and contributions of people with disability are overlooked in media, culture, or even policymaking. Lack of voice, people with disabilities are often denied the opportunity to speak for themselves, to participate in decision making that affect their lives in legislation or elsewhere, and devalued. That the work and contributions of people with disabilities are undervalued or dismissed. Again, these are all perspectives associated with otherness. And so I'm going to pause for a second. Have you observed the presence of the moral or medical model, the relics of these models in the mental health field? Have you observed otherness sustained in the mental health field, right? Have you observed any relics of the medical model? I'll go back to that slide and put in the chat. Have you observed any relics, any long-lasting effects or sentiments of the medical model in your work? Have you observed this piece of otherness? You can go ahead and put it in the chat or in the Q&A. From Stephanie, unfortunately, yes. Oh, I see someone wrote, it moved. Yes, families can sometimes infantilize their family members with mental health conditions. Dusty, with the thought of overprescribing meds before trying other methods and skill building count as a part of the medical model. Absolutely, overprescribing, having someone on excessive psychiatric medication can certainly be a part of that piece, right, of that medical model. The medical model really viewed the pathway to wellness was through psychotropic medication, and only psychotropic medication, right? It wasn't viewed as like, this is a tool in the toolbox. It was, this is the whole toolbox, right? This is what you have. We have medications and other medical interventions that, doctors, the PhDs need to provide. I've also seen it with family members. Okay, that's what another participant was saying, that it can be prevalent with family members. I know I was working with a partial care program, trying to assist someone in getting back to work. And they had their certification as a dental hygienist. And so like they did a lot to build a career. And yes, they had some hospitalizations, and yes, they had a mental health condition, and they were working to manage that mental health condition, but they also wanted to return to their career as a dental hygienist. And the partial care provider was adamant that they couldn't start going back to work until they started attending groups, all of their groups, until they started participating in all of their groups. They had to do this for like X amount of months for them to like approve or like sign off on their referral for employment services. And I thought, wow, if I had to sit in groups every day for several months before I could potentially go back to work, I might never go back to work. I don't know if I can do that, right? It's just not transferable, right? How I attend a group that I'm not getting paid to attend really doesn't have any bearing on whether or not I'm like prepared to go back to work, right? Maybe if you paid me to attend the group, like I do get paid to go to work, my attendance might look different, right? So when we think about the medical model and the models of disability and this piece about otherness, it really is an invitation for us to gently look inward and to get a sense of how historically our field may have really developed provider attitudes that could have impacted disability stigma, right? In 2018, there was a published study over perceived provider stigma as a predictor of mental health service users' utilization of service, their sense of internalized stigma and disempowerment. And this study really explored perceived stigma from individuals in service to get a sense of how it impacted them. And they found, right, that a lot of the study participants endorsed experiencing perceived stigma and negative reactions, including social distancing, right? Providers kind of distancing themselves from service utilizers. And that led to lower rates of service utilization, a sense of disempowerment, and a sense of internalized stigma, right? People were more likely to endorse internalized stigma when they had experienced a provider who may have endorsed, right, some of those medical model relics. We also see in some recent qualitative research that service utilizers indicated that stigmatizing attitudes and behaviors from professionals was a concern, listed as a primary concern in terms of developing an internalized stigma perspective, right? And in this study, they really highlighted that various ways that providers may have impacted that belief of internalized stigma included negative attitudes, discriminatory behaviors, and lack of empathy from practitioners, right? And so one of the key recommendations from that study, that qualitative study, was to look at anti-stigma training for us, the practitioners, for providers and organizations to support the development, right, of other ways to process and theorize models of disability. And so when we get to that place of, or that piece of internalized stigma, that is really what we're talking about when a person with that mental health condition internalizes negative stereotypes and those prejudicial beliefs or attitudes. And that internalization will lead to lower self-efficacy, lower self-esteem, and a reported lower overall quality of life. And this research, a lot of the good literature has come out of Dr. Phil Yanos and the folks at CUNY. He is one of the experts in internalized stigma, and he defines internalized stigma as a process by which an individual believes negative stereotypes about their group. and then they apply those beliefs to themselves. And he really, along with his colleague, Dr. Corrigan, theorized that building internalized stigma is a process. And Dr. Corrigan identifies that that process are the three A's. And we want to be mindful of this as practitioners to kind of get a sense of where the people are at in terms of folks that we're working with. Where are they at in potentially developing this self-stigma identity? And so those three A's include awareness, right? So the person in service recognizes societal stigma. They know about it, right? They can identify it. The second A is agreement. The individual with the mental health condition starts to agree with the societal stereotype they've become aware of, and now their belief is congruent, right? So if the societal belief is people with mental health conditions are incompetent, then that second phase would be agreement. Yes, I agree. People with mental health conditions are incompetent. And then the third and final phase of developing internalized stigma is application. And that's where the individual is now applying the agreed upon stereotype to themselves. And so not only they're saying society thinks people with mental health conditions are incompetent. Yes, I agree with this. And now they're saying in that final stage of application, because I have a mental health condition, I am incompetent, right? And so it's very important to get a sense of how this process develops and how we can disrupt it. Because when someone is experiencing that internalized stigma, we see profound impact on their health and wellness, especially in the social determinant domains of employment and education, right? So the literature clearly identifies when someone is endorsing internalized stigma, when they've got to that application stage from Dr. Corrigan's model, right? They're now identifying reduced self-efficacy in the work domain. They have reported lower job performance. They may report diminished career aspirations, right? When someone is experiencing internalized stigma and has that diminished self-efficacy, right? Their belief about careers and employment might be, it's not possible for me. I'm not capable. And they may cite interpersonal challenges at work. In the academic domain, we see increased school avoidance or dropout, again, because of that diminished self-efficacy. We may see diminished academic self-esteem, right? This notion that I can't, I'm unable, right? Because we are now at that place where the person is applying those pieces of societal beliefs or prejudicial attitudes to themselves. We also see with school impaired concentration or learning outcomes, as well as reluctance to seek support in the academic setting. And so the broader implications when we're talking about these social determinants of health related to stigma is that there's going to be an economic impact. If a person's unable to finish their education, whether it's secondary or post-secondary education, or they're not pursuing employment or seeking career advances, there will be a significant economic impact. That person may be precluded from the primary labor market because they didn't go on to receive education to get out of that secondary labor market. They may remain on benefits, right? There may be in that benefits trap where they believe that the best they're going to do is receive their Social Security disability check. And so what we know about diminished social determinants of health is that we see diminished overall health outcomes, right? Things that include higher cardiovascular risk, higher rates of diabetes, higher rates of even things like COPD. So when we think about, what is the impact of internalized stigma, it really is significant. It cuts right down to how people perform in the most fundamental social determinants of health, including employment and education. And when we see someone who is experiencing that impacted self-concept, right, then we're at this point where a person may be endorsing a sense of illness identity. So thinking about that for a second, I want to throw it back to the group. Have you observed that in the folks that you're working with? What does it look like? The folks that you are working with in services, do you see, um, diminished belief about work or education? Do you see, um, you know, the, people endorsing attitudes or beliefs that they are not able to achieve wellness and recovery in different life domains? I see I'm missing some things in a chat. Assuming all symptoms need to be treated with medication, even though the symptom is not. Yes, Jacob. Working nurses I worked with, yeah, Chloe. Yeah, there can be a lot of that medical model, definitely in inpatient facilities where a lot of the practitioners have been trained under that medical model. They may not have had exposure to other models. Great point. Case summaries and diagnoses of elder individuals from providers who are misdiagnosed or not adequately diagnosed, they were never addressed in a more modern and accurate context. Yeah, I would see that often. I had people coming in to support education services. They were in their 50s or 60s. They had many different iterations of diagnoses, many different iterations of psychotropic medication, and now they were trying to pick up the pieces and move forward, go back to school, go back to work. Learned helplessness to move forward. Yes, Christina, people can experience that challenge of just feeling immobilized because they truly believe now, right? They truly believe that they aren't able to move forward. That stigma is now a part of identity and self-concept. Jacob, do not have any long-term goals due to believing they're not. Yes, yes. It is very hard to envision a future when you have nothing in your well of hope to pull from, right? If you are coming from that medical model perspective where everything is deficit focused, right? What then do your future aspirations look like? Stephanie, yes, often I can't statements or I'll never get over this. Absolutely. We can see that a lot of those echoed sentiments from folks. I think integrating peers into the mental health system made a huge difference in preventing people from internal. Yes, Abby, that is a big part of building a positive disability identity. And we're going to get into that into a second, right? In our section of like, what do we do about this? It is building empowering messages. And a part of that is giving individuals connection to their community, connecting with people who have a shared lived experience to help those individuals build that positive support and support one another in their recovery. Dusty, I have a kind of opposite issue where I've seen this at a very high goal that has many steps and they get overwhelmed by all the steps and frustrated with the time and end up giving up despite, yeah, that can be a challenge, right? When people are setting goals, right? How do we help them to systematically set those SMART goals so that they're taking the steps that they can, right? Like they can manage, so that they can climb that mountain eventually. And that was a big part of what I did in support education. I worked with an individual, Dusty, who had significant symptoms of bipolar disorder. I helped that individual to go back to school, and they finished their bachelor's degree within like 5 or 6 years of me working with them. I then assisted them in the next 3 years in going to graduate school. Right, this was like very slow process. It was like, let's graduate or pass one class at a time, pass one test at a time. Eventually we get to graduation, and that person's now a medical doctor. They're in the field practicing, right? So we have to help that person to achieve that high goal in a very smart goal fashion, right? Helping them to get up each step or one rung up the ladder. And so when we think about this piece of illness identity, right, that internalization, that's where a person can really experience, as you guys identified, decreased motivation to pursue their aspirations, including in the domains of employment education, right? It's this perception where an individual may strongly identify with that model of disability. And so oftentimes we see a pairing of that illness identity and sick role, right? Where a person really feels that they're unable to take on healthy risks of going back to school, going back to work, taking on their recovery goals or aspirations for fear that it may exacerbate symptoms or that they're not capable or they won't amount to anything, right? Now we're at a place, right, where we may have to support this person in undoing system effects, unintentional system effects. But there are many things, right, that we can do to support a person who may be experiencing that diminished agency, that internalized stigma, that sense of, um, right, that loss of hope or optimism for their wellness and recovery. And so when we think about what are the steps that we can take as practitioners, the very first basic step is removing our conceptualization of services through the lens of the old antiquated models, right? We want to look at updated, informed, um, really social justice or disability justice model perspective of helping people with a disability. And so if we look at this next iteration of models of disability, we could see the social model of disability. And this represented a significant shift in understanding the presence of a disability, right? Moving away from viewing it as an individual problem and instead focusing on environmental factors, societal barriers, including societal attitudes and beliefs, right? This model really emphasizes that disability can be a result of the interaction between the person's condition and disabling barriers created by society. And it was really developed in response to the limitations and stigmatizing nature of the medical model, right? This kind of came about during the civil rights movement in the 60s and 70s. Mike Oliver, I think, was a key figure in the development of this model, arguing that disability is caused by the way society is organized rather than just a person's impairment or their difference. And according to this model, disability really arises when society fails to find ways to support equity and inclusion, to accommodate, right, the needs of individuals, um, creating, barriers to their full participation. And so we think about principles of this social model of disability. We can see that we want to look at inclusion and accessibility. We want to emphasize a person's rights and empowerment. We want to provide information, awareness, and education, and really finding ways to reduce internalized stigma, right? Changing perceptions, not just of the individual with the disability, but also their stakeholders, right? Their family, their other providers, right? The people that are within their support networks. We want to focus on empowering a person, finding strength in their identity, finding, right, coming from that like person-centered, strengths-based approach. And so I have, let me see, where did I put this? I am putting into the chat a Google document, and I think we can send this out. Can I put this in the chat? Let's see. Oh, you know what? I think I was just able to turn on the webinar chat. Can you guys confirm? But I put into the, oh, thank goodness. Okay. I'm putting again into the chat. This is a Google Doc that is going to go through the steps of reconfiguring your practice in this social model of disability, right? What are the ways, it's almost like a little bit of a checklist to check in to see, right? How are we emphasizing service that is through that social model of disability? And really, that social model of disability is pulling in from critical disability theory, right? This model infuses a social model of disability by really providing us as practitioners a comprehensive framework that examines power structures, cultural norms, social practices that contribute to, again, that marginalization and oppression of individuals with disabilities, like people with mental health conditions. And it's really an infusion of disability studies, critical race theory, pulling from that theory, and social justice movement. And so when we think about critical disability theory, it offers us a nuanced and intersectional approach to understanding disability. It really helps us to look at other social categories when we conceptualize service, including race, gender, socioeconomic status, affectional identity, and really drawing down the experience of that person and developing services based on all of those contextual factors. It considers the functional implications of the health condition, right? So how is that condition impacting, like what are the tangible effects that that person is experiencing based on their health condition? And what are the tangible effects of the societal barriers, right? What are the interactions between the health condition and those societal barriers? How are we removing both, right? What are we doing to be mindful of both of those contributing challenges? And there's this piece really about social justice, right? I am definitely a social justice counselor at heart. And when we think about this lens, reframing our philosophical approach, right, it's addressing those potentially systemic inequalities, seeking to empower the person through advocacy, policy change, through promoting equity and inclusion. And for me, that was simple as I mentioned that, partial care program that was saying, well, this person has to start attending group before we sign off on them, going back to employment, right? They have to be attending for months and months and they have to prove themselves. And so my advocacy really on like a micro or granular level is, well, let's think about that for a second, right? Is that a policy? Is there a way that we can collaborate on supporting this person and re-entering the world of work as they are simultaneously building their wellness skills? How can we, work collaboratively to address these needs together? So that is like step one, right? Kind of reshifting our theoretical lens. And step one really goes hand in hand with our advocacy through language. Our language is a primary means of expressing our beliefs and thoughts with the people that we work with. Our words convey messages. We don't want to bathe people in language that could create illness identity or endorse stigmatizing views. So I'm very mindful, right, of how am I developing language that supports and conveys hope, that conveys, person-centered approach. And there are different ways that we can do this. There is an approach called person first language, and that emphasizes person before the disability. So that would look like person with a disability, right? Individual with depression. This language is, something that came, I think, about during the disability rights movement, especially for individuals with mental health conditions, where like the verbiage used to include like, oh, they're schizophrenic, or any like pejorative, right? Associated with mental health conditions. And now we see, even like the APA 7th edition using or advocating for this person first language. And some people that's going to resonate with them. Other folks, they may prefer identity first language. And that is a model of language that is common in disability spaces, and that may put the piece of disability first. So if I'm using an identity first language model, that might look like disabled individual, autistic person, or autistic people, right? Even like subgroups like the deaf community, right? Strongly identify with their disability, and capital D deaf community will use their disability term in identity first language. So we would just want to be mindful, like how are we navigating this piece on language? How are we honoring a person's preferences, and what are we using to reduce likelihood of building illness identity? And we build in the illness identity when we're inadvertently conveying lack of hope, right? Pessimism, disbelief that the person can potentially recover, right? Projecting that medical model. We also want to be very mindful of our efforts in building a positive disability identity. Disability identity refers to the way an individual with a disability perceives and integrates their disability into their overall self-concept. It really encompasses recognition, acceptance, and incorporation of one's disability as a meaningful and valuable part of their identity. And this can be uh, a really strong portion of what we do, in our services, helping the person to reflect on their strengths, right? Reflection of strengths and building those strengths is a key piece of disability identity. Someone mentioned peers previously. Community connection is another facilitating factor of positive disability identity, right? Feeling a sense of belonging to their disability community, connecting with people with similar experiences, providing that social support, shared understanding, just having that collective voice for advocacy. All of that piece of community connection can drive a positive disability identity. Finding opportunities for empowerment and advocacy. I was working on a project where we were, speaking to individuals with mental health conditions who were in school. And they talked about, their peer roles and how being in a role where they're helping others, giving back to their community, that advocacy work, that empowerment work was a key driving factor in building their positive disability identity, right? Being able to not just connect with the community, but to find ways to make a difference on a micro scale of helping one individual or several individuals that they were working with, or doing more macro level advocacy, like working with Disability Rights New Jersey, and looking at systems and structural change. And so when we think about, that disability identity and building positive disability identity, I believe there are a couple of recommendations on that worksheet in the Google Drive to really bring that work to your forefront, right? How are we finding opportunities to build connection and community with the person we're working with? How are we managing that building of self-acceptance or strength-based identity? Another approach that has been utilized to support the work of reducing internalized stigma comes with, I think I mentioned Dr. Yanos earlier. He is really renowned for his work on internalized stigma, and his evidence-based approach is using narrative enhancement and cognitive therapy. This is a structured approach designed to help individuals with mental health conditions to really combat that self-stigma. And the key principles of this approach really include like psychoeducation, right? Providing information, kind of like demystifying for people how they got these views, right? Providing information about stigma and the effects of stigma on them, helping the individual to understand that stigma is a social construct and not a reflection of them, their identity, or their personal worth. So that's principle one, is that psychoeducation. And then we also see Dr. Yanos utilizing something that's very powerful for kind of breaking down the internalized stigma and prejudicial attitudes, which is cognitive restructuring. Cognitive restructuring helps a person to identify and challenge negative beliefs and thoughts related to self-stigma, right? And more importantly, it encourages the development of alternative positive self-beliefs, right? So it's looking at the negative beliefs, challenging them, and then kind of rewriting that narrative. What are the positive beliefs, right? So if the cognitive distortion is I am someone who has a mental health condition and I am worthless, right? Challenging that belief, right? Looking at the evidence for and against, using that cognitive restructuring worksheet, and then helping them to develop a more reality-based thought like, hey, I am really strong. I am someone who has gone through uh, many challenges and I have made it out successfully, right? So replacing those self-deprecating, internalized stigma, endorsed thoughts with a more positive self-belief that reflects their actual reality. Narrative enhancement part of this intervention is they're encouraged to share their life stories, share their new perspectives and beliefs in supportive group settings. And the facilitators help that individual to kind of reframe their narrative at times, highlighting their strengths, achievements, and positive experiences. So that might look like, someone who comes into a session saying, hey, like, I can't keep a job. I only had my job for, 5 months. That facilitator in that narrative enhancement group is going to say like, wow, 5 months, you did amazing. You kept that job. That is longer than you have kept a job in the past. Tell me, like, what did you do well about that, right? So really digging deep to find the positives and kind of that reframe to highlight the strengths that they may be missing. They may have blinders on due to that ingrained, internalized, prejudicial belief, right? That internalized stigma. And then there's this last part, last principle, which is skills training, enhancing the individual's skills, problem-solving skills, assertiveness skills, advocacy skills to boost confidence and reduce the impact of stigma in those social interactions. So I've actually worked with Dr. Yanos on a few studies. I've seen this in practice for folks, who um, may be experiencing some of that internalized stigma, specifically with mental health conditions, and more specifically with folks who have trauma and PTSD. And it's pretty powerful, right? We see that it impacts in positive ways how people conceptualize, right, self and identify. Um, Ultimately, hopefully building that positive disability identity. And so again, thinking about like what we can do in our services, what we can offer. Um, a lot of us, right, probably not trained on that narrative enhancement and cognitive therapy. No worries, right? If that's not something that you can receive training on or have access to, a lot of us utilize cognitive behavioral therapy. And that is one of the key pieces of what makes Dr. Yanos's work very successful, right? So even just doing some of that basic CBT, that cognitive behavioral therapy, to help address those pattern ways of thinking, right? Those pattern ways of thinking that may be self-deprecating, that may be endorsing illness identity or internalized stigma. So this can be particularly effective in addressing um, those negative self-thoughts and be assistive in developing that positive disability identity. And so what do we see with CBT? We see that there is that cognitive restructuring piece, right, where the person and you are working together to identify challenging negative thoughts and beliefs about themselves, about their mental health condition, and helping them to reframe those negative beliefs in a more positive and evidence-based endorsing thought. We also can use behavioral activation from CBT, encouraging engagement in meaningful activities, helping that person to feel more empowered to engage that positive self efficacy or agency, and to reduce those feelings of helplessness. I've used CBT in my practice for many years, um, and it's been pretty powerful in helping people to assess some of those internalized pieces of stigma, to challenge them, and to develop through that cognitive restructuring new thoughts that support that positive disability identity, right? That I am powerful, that I do have strengths. And here is the evidence that suggests that. One of my most favorite ways of helping people to explore that positive disability identity, to develop a sense of empowerment, to support that piece of the social model of disability, is using the evidence-based practice of Mary Ellen Copeland, which is the Wellness Recovery Action Plan. For those of you not familiar, Mary Ellen Copeland was a person who also had a mental health condition, and she was just very tired of hearing, you'll feel better when. You'll feel better when you have the right medication, when you have the right dosage of medication, when you have the right combination of medication. You'll feel better when. And she just said to herself, there has to be something that I can do to impact my own health trajectory. Yes, medication is great. It's a tool in my toolbox, but what can I do while I'm waiting to support my own wellness, right? Building that self-efficacy, that empowerment, that sense of hope. So Mary Ellen Copeland developed in 1997 RAP, and this was designed to help people with mental health conditions really assess what are the things that are in their locus of control. What can they do on a daily or weekly basis to impact and influence their own mental health trajectory, right? It helps you to really assess what's in your locus of control and what can you do to maintain wellness and manage stress. So there are core components of RAP, things like a wellness toolbox, your list of resources such as activities, skills, strategies, the things that you do to keep yourself well. Then there's a daily maintenance plan that includes activities to help that individual maintain that wellness. There's a section on triggers, identifying external events or circumstances that cause stress or discomfort. Early warning sign section, recognizing signs that indicate that they may not be feeling their best, that things are getting worse. And then a section on crisis, when things are breaking down, right? Identifying, when wellness is kind of deteriorating. And then crisis planning to help that person to develop a plan in preparation for if they experience a crisis, what would they want done when they're in crisis? That way, there is a documented plan that they created when they were feeling well as to what they want to happen when in that moment they're maybe not feeling their best and may not be able to articulate, right? What are the things that I would like to happen for my care? Right? What hospital would I want to go to? Or would I want to go to a respite center? Would I want, certain medications or not take certain medications because I had bad reactions? Who would be supporting me, right? Who from my support circle are we calling in? So RAP is so powerful. I have used it in across many domains. I use RAP for work, RAP for education. When I was doing support education services in New Jersey, I just use RAP, the OG model, but it's so fabulous in building that sense of empowerment, hope, self-efficacy, and agency. It can really help people to kind of question that medical model, right? Is is my mental health contingent upon this hierarchy of prescribing providers? Or can I do things along the way to also help my wellness, right? How can I expand my wellness toolbox to have medication in, right? What's in my locus of control, and what can I do to support feeling good? Are you guys familiar with PrEP? You could put in the chat. I know we do a lot of trainings here in New Jersey on it. I recently completed one specific to RAP for work, which looks a little bit different. From Christina, I'm certified. Ah, that's amazing. That's awesome. Yeah, it's a great evidence-based tool, and it's a fun process to do with a person. You get to learn so much about them and help them to have that exploratory process of what are the things that they like to do? What are the things that light them up, that What are the things that they do to feel their best, right? When they're the best version of themselves. And how do we do more of it? How do we do it more often, more frequently? How do we do it when we're not feeling good to impact our wellness? Yes, Christina, helping them to feel empowered for making choices for themselves, supporting that agency, right? They're in the driver's seat. You love sharing rap and facilitating with others. Yeah, it is a really enjoyable practice that builds connection between you and the person that you're supporting. And then this last piece, right, in terms of how do we support a person in reducing internalized stigma, comes from Dr. Pat Deegan. Dr. Pat Deegan is a renowned psychologist, researcher, and advocate in the field of mental health recovery. She's a person with lived experience of schizophrenia. And she really had, I think, a lot in terms of promoting the rights and recovery of individuals with psychiatric disabilities. Right? She's a very fierce advocate. And so she has this concept of dignity of risk. And this emphasizes the importance of allowing individuals the freedom to make choices and take risks as a part of their recovery, right? And this principle challenges the traditional medical model, right? That, and it again goes back to that critical disability theory approach of autonomy and empowerment. And just like Christina said, helping a person to make their own choices. So we think of the concept of dignity of risk, it's helping a person to take that risk, to go back to work, to go back to school, to make the choices that might lead to, what we might view as potential failure or that something that could, upset someone, right? But the ability to make the choice to experience that failure, to learn from those experiences and to grow from it. And so there is a worksheet that I will be sending out that just helps practitioners to assess, right? Am I managing that dignity of risk with duty to care? Duty to care is the way that practitioners may feel, right? That we have to step in to protect someone from a risk. And when is it ever okay for a practitioner to step in, like the partial care program that I was talking to you about earlier, right? If they had done the worksheet of managing dignity of risk and duty to care, right? The outcome of that would be that the partial care program needs to really support that dignity of risk and going back to work, right? So I know I threw a lot at you in our 90 minutes. We have 2 minutes left. We talked a bit about, um, again, what stigma and disability stigma is, the history behind it, and one of the biggest locus of control for us as practitioners is reducing the ways that our field may inadvertently perpetuate through that medical model, stigma and illness identity. So any questions? Any questions? You could put in the chat, checking now to see if I missed anything. Yes, I love rap too. It's one of my favorite. I'm gonna put into the chat, let's see, our satisfaction survey for today. Please take a moment to fill it out. We review these. Washington State reviews them. Thank you so much for attending. Again, I'm going to put into the chat. I also have that little QR code up for our survey, but please feel free to complete that. They do get reviewed. And I think the Washington State folks do review it too when they're considering what learning communities people want more of, less of. So please definitely put your feedback in because your folks in the division do read them, do pay attention to them, and take your suggestions to meet your needs so that you are getting what you need to provide the services that you do every day, the amazing services that you offer for people and helping them on their wellness and recovery journey. You will be getting the slides and the handouts. Yes, you will have the recording. That typically comes out through the Washington State folks. They will send an email to everyone who registered with the recording, with the PowerPoint slides, with all of the tools. If RAP is something that you guys are interested in for future sessions, definitely put it in your feedback, right? That is something that we can certainly provide a session on, a session or two. Thank you so much for your attendance. I know how busy you folks are. Your time is so valuable. So to be here for these last 90 minutes to spend some time together talking about service provision, I greatly appreciate it. Okay, if we don't have any questions, then I am going to give another minute or two for folks to get that survey link, and then I'm going to close our virtual meeting. I hope to see you guys in future sessions. Thank you so much for your attendance. Make sure I'm not missing anything. Oh, Dusty, I see this question about how it helps someone who changed their mind on what they want. That's so interesting. I just did a training on this for the New Jersey folks. Um, when someone is frequently changing their recovery goal, there could be a multitude of factors. And we kind of have to be a sleuth, if you will, a bit of a detective, and figure out what could be the reason. And sometimes the reason that a person is changing their goals so frequently is they may not have a good understanding of a goal that aligns with their interests and values and preferences. And so sometimes doing some of that groundwork, helping them to explore, right, what their values, interests, and preferences are, can help them to better align a goal that is meaningful to them. And I do a lot of MI work, motivational interviewing work, for folks that may have a lot of that ambivalence, right? MI is a great tool to utilize when someone is experiencing that ambivalence. Okay, folks, I am going to close down our meeting. If you do want to reach out with any other questions, I'm going to put my email in the chat. Thank you so much for your time. I hope to see you guys in future sessions. Be well, and hopefully I'll see you guys in March. Bye.